Yes.
Smile, if you did.
I'm so sorry. Am I audible now?
Yes.
Yeah. So, a very good evening to everybody, and thank you for joining today's webinar on where precision technology meets holistic healing. The subject is intriguing, and the discussion with our two panelists from Chennai-based Buddhi Clinic promises to be interesting. They will talk about their new integrated medicine approach that combines new age technology, ancient traditions, modern therapy, and rehabilitation for treating various kinds of brain disorders. If the model of interventional neuropsychiatry is mainstreamed, it could become a purposeful and empowering intervention in treating neurological diversity and caring for the mental health of the young and the adult population. As findings show, it helps to reactivate the full spectrum of human potential following any injury to the brain. Over the years, the Buddhi Clinic has been combining cutting edge neurotechnology and modern therapies with traditional healing. What they have included in their revolutionized treatment for the body, mind, and the spine are minimally invasive surgeries, non invasive brain stimulation, along with some tailored therapy plans and precision medicines. It is yielding patient centric and enhanced outcomes. Children with autism and cerebral palsy, adults with epilepsy, migraine, depression, schizophrenia, Parkinson's, Alzheimer's, bipolar disorder, and other related conditions have reported positive results. To talk more about this fascinating approach that integrates non invasive brain stimulation with advanced rehabilitation for better mobility, memory, speech, swallowing, spine, and musculoskeletal health and mental well being, we have the founder of Buddhi Clinic and Neurokrish Foundation, Dr. Ennapadam S. Krishnamurthy, and Dr. Vivek Mishra, Director of Clinical Neurosciences and Neurotechnology at Buddhi Clinic, Chennai. I welcome you, doctors.
Thank you so much.
Today's webinar is presented by Buddhi Clinic in association with The Hindu under its Wellness series. So now I'll get on with the introductions. Dr. Krishnamurthy is a well-known behavioral neurologist and neuropsychiatrist who has pioneered the integrated and holistic care and rehabilitation of the brain and mind. He has taken on multiple international leadership roles in the clinical science and treatment of epilepsy, dementia, and neuropsychiatric disorders. Dr. Krishnamurthy is the immediate past president of the International Neuropsychiatric Association and the editor of the Global Approach series for Cambridge University Press and Neuropsychiatry Across Cultures for Oxford University Press. He has to his credit 70 plus scientific papers, 30 plus book chapters, and over 25 articles in the lay press, and has lectured widely across 4 continents. He convenes the T.S. Srinivasan Conclave and Oration annually, is adjunct professor at Manipal University and Public Health Foundation, India. He is also Senior Clinical Advisor Neurosciences, Apollo Hospitals Group. Our second panelist, Dr. Vivek Mishra, did his MS in Clinical Neuroscience from Faculty of Medicine, University of Madras, and he followed it up with a fellowship in brain stimulation from Rambam Healthcare Campus, Haifa, Israel. An elected life member of Indian Academy of Neurosciences and Indian Epilepsy Society, he has also served as the director and executive committee member of the International Neuropsychiatric Association, besides being the assistant editor of Cambridge University Press book series, A Global Approach, Dementia and Epilepsy. Dr. Mishra's current research focuses upon application of non-invasive brain stimulation and precision medicine in a range of neuropsychiatric disorders. So it's over to you first, Dr. Vivek Mishra, for your presentation on the new robotic technology and how it is being advanced to non-invasive brain stimulation for rehabilitation programs. Welcome.
Yeah. Good evening, all. So I will start with sharing my slides. Yeah. So, good evening to one and all who present here. And I would like to talk about the brain, spine, and the mind, where the precision technology meets the holistic healing. First, the snapshot that what we are talking about and why it is important to talk about. If we just look the global numbers, we are looking for 1 billion people in the world out of 8 billion suffers from the neurological disorders and disability. 80% of those living in the developing countries. There are roughly 317 million children with various neurodevelopmental disabilities exist across globe. And it has been estimated that if we look overall, 46% of older people age 60 years and over are having with disabilities. Neurological disorders are the leading cause of disability adjusted life years. One in every 8 people, or 970 million people around the world, are living with the mental disorders, with anxiety, depression, depressive disorders are the most common of them. And in fact, in 2020, because of course, what we saw is the post-acute sequelae of COVID-19, there is a sudden increase up to 26 and 28% respectively for just looking for anxiety and major depressive disorders in just 1 year. And still we are looking at the same numbers. So, with the global burden of the disorders are raising, it's roughly 50%. And what are the most common disorders, neurological disorders? What we see is paralysis, the stroke, Alzheimer's disease, epilepsy. We are talking about migraine, Parkinson's, and of course, the other brain tumors and traumatic brain injuries. To just go through little bit how we understand the brain functioning. Brain is just like a symphony, our brain is just an orchestra of a complex networks of neuron conducting the music of our thoughts, emotions, and actions. So when this symphony gets out of the tune, or we say the neurological or psychiatric condition arise, it may be the stroke, Parkinson's disease, depression, mood disorders. So what is the challenges? The pharmacotherapy have limitations. For if we just look at the data, post-stroke residual disability affecting around 80% of the patients. Parkinson's disease have seen dramatic increase to 81% rise in Delhi. So Delhi is the disability adjusted life years. So if I have a Parkinson's and there's one day is gone due to the disability, it's 81%, like 5.8 million days are being affected if we look the global data. Limited efficacy, side effects can also hinder the adherence to the treatment of the neurological rehabilitation. So we, as a scientist, look toward the brain plasticity. The brain's is not static. We know that it keeps on learning, it adapts, it changes. This ability to change is called the neuroplasticity. Non-invasive brain stimulation harness this neuroplasticity for the therapeutic purposes. So when we come to the comprehensive rehabilitation approach, what we are talking about? A comprehensive rehabilitation can integrate physical therapy with brain stimulation techniques to enhance the neuroplasticity and improve the motor, cognitive, and functional outcomes. This combined approach is known as the neuromodulation, is often used to treat conditions like stroke, Parkinson's, traumatic brain injury, and it have to be a comprehensive one because if we just work on the body and not stimulate the brain or the vice versa, we are not able to tap to this potential of the neuroplasticity. So how we are doing it? So the toolbox, what we consider is using the repetitive transcranial magnetic stimulation, which uses the magnetic pulses to stimulate specific brain regions. TDCS or TES, it is transcranial electrical stimulation, which uses weak electrical stimulus to modulate the brain activity. Vagus nerve stimulation, especially when we use the transcutaneous auricular version, which is without any surgery, it can be stimulated from outside. Neurofeedback is again it's a QEEG based device, which is a quantitative electrical encephalography, where we can able to map the brain regions which are out of sync. FMS uses high intensity magnetic pulses to stimulate an affected nerve or muscle groups. So I just want to take everyone through what are these technologies are. So the TMS, as you see, like it's just a coil which can able to produce the up to 4 Tesla of magnetic flux, and it is very focused. It stimulates only particular brain regions which are being affected. It is painless, it is non-invasive, and the method require no anesthesia or sedation. There is no generation of seizure. So usually when we talk about the TMS and people like think it is the just old version of the shock therapy, it is not. The people are quite very much conscious and they don't feel much pain. And there is a biological evidence. So if we just see that if we able to stimulate over the period of time, we can activate the brain or inhibit the brain if so the condition required. So there is very much a biological proof to it. We talk about transcranial direct current stimulation, which is in very simple term, it's fine tuning the brain circuit with the electricity. It uses very mild electrical currents up to 1 to 2 milliamps. And as you see in the photograph, so there are two electrodes which have been placed over the forehead and able to a person sits usually sits on the recliner, and we can able to stimulate very particular brain networks which can cause depression, anxiety, mild cognitive impairment, speech, motor symptoms in conditions like stroke, multiple sclerosis. Also, is all like it's developing into providing a very effective outcome measures for people, children with ADHD, ASD. Now, when we say ASD and ADHD, it is the core behavioral output what we are able to stimulate. Again, TDCS is painless, non-invasive, is well tolerable across lifespan. If we can look the data, a 6 years and above can able to tolerate the TDCS without any adverse effect. Of course, we do a comprehensive assessment and screening so that we can prevent whatsoever adverse effects are. Give me a second. Okay. Transcutaneous auricular vagus nerve stimulation. It's tapping the brain body brain connection. So prior to 2013, the vagus nerve stimulation was an implant where a surgeon can fit a mild battery or a device here and wrap the nerve over on our left neck. But now we can able to stimulate the same using the auricular branch of the vagus nerve, which just passes from our left ear, like it passes from both, but we choose to stimulate from the left due to the anatomy where we are looking for it not directly interfere with the aortic branch of the vagus nerve. Now, when the vagus nerve is stimulated, it is we know that it is a key player in body's stress response system. TAVNS is found to be effective in management of people with epilepsy, vertigo, cluster headache, dysautonomia, and regulating the gut-brain axis. Now, when we just highlight the dysautonomia, roughly 60% of the people with Parkinson's disease presents with dysautonomia. Post-acute sequelae of COVID-19, roughly 5% people up to 2 years presented with dysautonomia. So targeting the vagus nerve provides a very key, a target for us to stimulate the substrate. Usually the sessions are carried out, it's about 20 to 30 minutes, which are can be done in just an outpatient setting. Neurofeedback, it is training the brain to train itself. So if I have to explain the QEEG based neurofeedback, it's just like the matrix. So as you see this kid in the photograph, it's been wearing a cap which is plugged with a neurofeedback device, and the kid have to move the animation, the car game, or the movies using the brain wave pattern. So there is no joystick what you can use to move the car, but if you are focused, you can able to move the car. So the advantage of these, we are training the repeated stimulus over those brain networks which we want to train without externally stimulating them. It is very well studied and being used in ADHD, kids with ADHD, anxiety, depression, autism, insomnia. In fact, in drug addiction and schizophrenia, it can be used. But when we look about very specific parameters for the stroke, when we talk about stimulating those networks from acute stage to chronic state, we can able to switch the paradigm and can modulate those brain networks as the disease the progress. So like when we have the acute phase, there is a different parameters what we can use. So it is very personalized to that person. There is every person, the every patient we see is different, and using one size fits all won't help, and the neurofeedback help us to personalize the treatment for each of the patient. Now, functional magnetic stimulation, or the FMS, previously known as a peripheral magnetic stimulation, is just like a TMS but for the body. It uses very high intensity magnetic pulses to enhance the rehabilitation process and relieve pain. One of the newer advances what we have been doing for last 3 years in Buddhi Clinic is to treat the spinal cord injuries, prolonged shoulder, the treatment of fibromyalgia, which is an unexplained chronic pain syndrome, where you can do all the tests and then it comes out negative, but we don't still know why the patient is having pain. Stimulating the brain as well as the region where the patient is feeling pain with the magnetic field can able to relieve the symptoms of pain. And the latest advancement in use of the FMS is the urinary incontinence, and the protocols is quite fascinating that when we see that there is no apparent solution for the neurogenic bladder apart from wearing a catheter, but when we able to stimulate the sacral ganglion root in our spinal cord, we can able to show the differences up to 80% bladder control in just 6 sessions. So I think those are like one of the few devices which can bring such a change when we talk about in the rehabilitation. And of course, now, when we say the rehabilitation, everyone's talk about the EMG-based devices and the robotics. Now, but is the robotic therapy what people are getting across the country, is it intelligent? Well, there are some IFES, which is the integrated functional electrical stimulation therapy systems. And why these things are called the therapy systems? Because it's just not only help a patient move the hand, the legs, or the core, but able to sense the muscle activity in real time. So, for example, when there is a patient want to go on the RT300 bike, what you can see on your left side of the screen, and the patient is saying like, I have stroke, there is no power in my hand, I can only do 20%. So what happens next? The machine senses the EMG data in the real time, provide the 80% of the output, and the task has been accomplished. So when the patient is doing again and again, we can able to see that the machine output will be just remain 20% over like 8 weeks to 9 weeks of the therapy, and the patient is giving the output. Well, that's the marker of improvement what we can see. And when clubbed with the brain stimulation, so we stimulated the area which have got the stroke, and be able to mobilize the same area, the be it a hand, legs, the spasticity, the tremor, and able to do the activities using the Excite 2. It is that brain body connection is complete. And of course, the gait balance using the sensor-based treadmills, where the balance also get trained, fine motor activities, like one of the devices what you can see on the screen. It's called the Galanter. It is an innovation from the IIT Gandhinagar. And one of the best device what I have seen in our setup, which is available in India. It is like it, and the results are very fascinating when we talk about the fine motor activation, be it the shoulder movements. It is really impressive work. But the point again, I would like to say, we stimulated the brain, we mobilized the hands, we mobilized the fine tunings of the fingers, and that's what brings the patient to use the mobile phone, eat properly, able to use the gadgets, or able to eat. So there is that the circuit which gets complete. So the highlight, what we would like to present is how the scenario is changing. When we look at the centers, the good centers in US, we look at good centers in Europe, which are providing really cutting edge neuro rehabilitation, which starts from 3 weeks and onwards. To do a rehabilitation 3 weeks and onward from the stroke or Parkinson, like when the diagnosis get to know what the intelligent systems are. We can do neuroimaging based targeted interventions. We can do TDCS and RTMS, again, aided by the navigational devices. We can take the real time data from our muscle activity, able to mobilize the upper hand, lower hand. We can see the real time brain activity in the QEEG based neurofeedback. AI interventions like VR therapies, what is found to be very effective in patients with even with a mild cognitive impairment, post-traumatic stress disorder, the trauma, because it gives that ability to tap into our neuroplasticity. And this is just not on the theory aspect. There are lots of papers, if I can just show a glimpse of it. Now, TDCS in cognition, over 201 senior with mild cognitive neurocognitive disorders being published. There are data for non-invasive brain stimulation in improving post-stroke rehabilitation. There are new targets which is being published for depression, post-stroke depression, post-stroke dysarthria, inability to like swallow properly. We can able to use the surface EMG-based devices like vital stints. And this is few of our data what when we see. So when a patient comes, so this is a Beck's depression inventory. And when we look at the 20th session and at the even the 8 week follow-up, we see the scores on depression rating scale, it goes significantly down. And roughly the our own data, when we look, it's a 73% of the people going under this approach of having the TMS, psychotherapy, cognitive behavioral therapy combined achieves the remission. So again, it is a very the marker that all these combination works. It's not just the TMS or just the psychotherapy. It is a synergistic effect what brings the change. Parkinson's. Now we all know that it is a progressive neurodegenerative disorder. We can look the change in the unified Parkinson's disease rating scale over the period just 20 sessions, 5 weeks, and we can able to see that they are more much better in their both physical and the mental domain. Again, lots of literature which is there that there are multifocal repetitive transcranial magnetic stimulation for motor and mood symptoms in Parkinson's. We are talking about the tremor control. We talk about the NIBS in spinal cord injuries. And this is like, this is one of the first patient when we started recruiting the patients for Parkinson's into back in 2018. And since then, I think we have come a long way and delivering about 35,000 sessions. But so there is this Miss N who was, when she came to us, was 72 years old, took the TMS. And she says verbatim that my hand was never so steady, nor I was able to concentrate on the mental task in last 10 years as I can do now post treatment. And she took the TMS. So even post 10 years of diagnosis, so she was living with Parkinson's for nearly 10 years. She had diagnosis when she was 62. And at 72, when she took the treatment, there is still very the hope for her and the other people with Parkinson's that there is a recovery possible. And of course, there are treatments when we look like which are more minimally invasive. There is a separate thing, but when there is a non-invasive modulation available, why not? Again, our own data that patients with Parkinson's not only improve physically, but psychologically and socially. Because when I am able to perform the task, I can go to my social gathering, I can meet my relatives and friends. So, and again, environmental factors do increase. So I will just like to conclude that non-invasive brain stimulation is a very valuable research and potential in therapeutic application and cognitive neuroscience, neurophysiology, and psychology. But integration of these non-invasive brain stimulation in advanced neurorehabilitation, paving our way to stimulate, modulate, and enhance the recovery process. So with that, thank you for your attention. I will stop my slides here.
Thank you, Dr. Mishra, for that very detailed outlining of the new treatment model. Dr. Krishnamurthy, now we'll move on to you. If you could tell the audience about the relevance of this innovative option available to patients, the different conditions you treat and care for, and so on.
Thank you so much. Our patients, cover the entire lifespan. So our youngest patients are just a few months. Our oldest are well into their 90s. So from neurodevelopmental disorders.
Sir, could you kindly improve the audio quality?
Sure. Is this better?
Yes. Okay.
So our youngest patients are about 2 or 3 months old. Our oldest patients are well beyond their 90s, and we are able to work with them in a complex way. Now, if you think about it from a rehabilitation perspective, disorders of brain mind, three M's get affected. Your memory gets affected, your mobility gets affected, your mental health gets affected. Two L's get affected. One L is lifestyle, sleep, appetite, digestion. All these things can get affected. The other L is language. In a number of neurological disorders, development language. So when we think about the three M's and the two L's, then we need to think about targeted interventions that can help with these. Now, the gold standard in rehabilitation, whether it's neurology or psychiatry, is multidisciplinary care. And multidisciplinary care is usually performed by teams that include physical therapists, occupational therapists, speech therapists, psychological therapists, working hand in hand together. The Buddhi Clinic innovation for rehabilitation, both for neurology and mental health, was the use of Ayurveda. So bringing in Ayurveda, yoga, and was the first generation. That's something we've now done for years and years and years. Combining multidisciplinary therapy with Ayush is something that we started doing in 2009. But now, in the last few years, we've brought in a whole house of non invasive brain stimulation. So we are literally sitting here inside a laboratory surrounded by about 15 technologies. Now, there are two types of technologies that we have, some that stimulate the brain, some that stimulate the musculoskeletal system, etc., as Vivek has been presenting. But the new innovations are robotic technologies that work with you as you work with inefficient limbs, for example. Now, when you take the approach that I will only do one kind of treatment, for example, I will only engage in robotic physiotherapy, then what happens is you're limiting yourself to what your limbs can do when stimulated and when a physiotherapist works with you. When you're able to stimulate your brain using a non invasive brain stimulation technique, along with robotic physiotherapy, you are able to train your brain to work better. So we are leveraging on neuroplasticity, which is something that we all have. The brain was thought to be a static organ. Many years ago, when they did the London cab driver study, that's when they realized that when they tracked the London cab driver, and their brain size, the hippocampal size, as they learned the London maps in their head, they found that the hippocampus actually increased in size in the 2 years. And that was the first evidence that the brain was a plastic organ. And the brain can be trained, the brain can even grow in size when you use parts of it. And of course, if I can take you back also to the phantoms in the brain, research by V.S. Ramachandran, again, this is what he talks about, how when you lose a limb, your limb then gets represented in another part of your brain. So it's not as if it ever goes away completely as far as the brain is concerned. So your brain is plastic. And when you stimulate the plastic brain and you train your plastic brain, along with physiotherapy, along with cognitive therapy, occupational therapy, speech therapy, psychological therapy, various forms of rehabilitation, you're able to bring about significant changes in your functioning. So the three M's and the two L's can all improve. One of the problems we have, of course, is that a lot of people give up very easily. They think that, oh, I've had a stroke, I've not got better for the last 2 months, there's no chance that I'll get better. And then somewhere along the way, your efforts at rehabilitation taper off.
The same happens with Parkinson's disease or with Alzheimer's dementia or even with depression and OCD. After a while, trying a few things, people start feeling that, oh, I cannot be helped. Now, what the new technology does is it brings hope to all these people. If you are a sufferer, if you've had symptoms that have not responded either to medication or to conventional therapy, then you really should consider the new technologies because they offer a certain kind of hope, especially when combined with human services, therapy and rehabilitation. So, what we'd like to bring awareness through this webinar is that this is a very powerful combination. And in our experience of innovating this combination, we have had such good success that we are very positive and confident about this becoming a model of care, not just something that we alone practice, something that we feel should be practiced widely. And recently, we were at a National Neuromodulation Congress, Brain Stimulation Congress, and we are very happy to see that more and more people are taking up these technologies in a very, very wide way across the country. So it's not something that's happening in limited spaces. Even the best centers around the country are adopting more and more of these technologies. So I think the big message really is to stay hopeful and to look at this combination of neurotechnology and therapy as a means of getting better, as an adjuvant to pharmacology, as an adjuvant to multidisciplinary care. It's not as if this replaces that. This actually gives that a huge impetus, which is important. Happy to take questions. Yeah.
Yeah. So as we understand, doctor, uh, as you both mentioned, how the landscape of neurological rehabilitation has changed in recent years. So this, what you call this restorative robotic technology, like what difference is it making, say, in terms of the time span, like the smooth recovery of the patient or even the cost of treatment or the number of sessions, because you said it's difficult to follow up or even patients drop off.
Sure.
Uh,
Let me give you some clinical feedback first, and then I'll get Vivek to give you some scientific feedback. So we've had this gentleman, for example, who had been on a wheelchair for 2 years with Parkinson's, and he came to us with a lot of hope. He actually traveled from quite a long way to come, and he came and stayed in a city where he was a stranger to take treatment. And the very, very interesting thing was that in the period that we stimulated his brain and put him through the IFES and gave him the multidisciplinary therapies that I was talking about, in the 5 week program that he did, he went from being on a wheelchair to not just walking on his own, he was able to walk backwards on his own. I mean, that's a huge change. And this, as a doctor, witnessing that, so I'm always hopeful when people come to us, but when I see a change like that, I am impressed because it means that, when we do this, it brings about a huge difference to the person. And of course, his family, including a son who lived abroad and was tracking this progress, were very, very gratified because they never thought that this person would walk again. I mean, there's an elder in your family, and you're very sad to see them confined to a wheelchair and needing assistance for everything. So that's a clinical example of something I have witnessed, which gave me a lot of hope. And of course, we've got a number of examples like that on a monthly basis. We get people off wheelchairs, and it's not mumbo jumbo. It is hardcore rehabilitation aided by technology. And I want to make that point that we're not looking at magic here. We're not promising something outlandish. Our experience is working with hardcore rehabilitation aided by technology, but with multidisciplinary therapy delivered by experts. I mean, that doesn't change. That's always the core that you need expert physiotherapists, occupational therapists, speech therapists, and psychologists to work with people. But when you also use technology, you get that qualitative difference. And I think two things change. One is the speed at which people can get better. That changes. And the other, the confidence of both the patient and the treating team, both. This is very, very crucial that both together feel very confident about the kind of changes that are happening. So this is my clinical feedback on how IFES together with brain stimulation can actually make a difference. I'm going to get Vivek to talk about how technologically it makes a difference.
Yeah, so
So,
the treatment is kind of getting enhanced.
The
And
treatment is getting enhanced. Absolutely.
and you did mention about this particular case of the gentleman on wheelchair and getting. So are these kind of cases one in a kind, or you have lots more in the statistics as per your clinics?
Several more. So, we've worked with thousands of patients from 22 states and 23 countries. And basically, we've had very good results. And of course, we keep adding technology. So it's not as if all these people have had all the technologies. But as we add technologies, our confidence about individual symptoms. I'll give you another example: speech and swallowing. Targeted technologies that help speech and swallowing have now become available. So when I work with somebody post stroke or post brain injury or post Parkinson's who has a problem with speech and swallowing, we are now able to use targeted stimulation for that, and that makes a big difference to that particular aspect. And of course, as you'll understand, for someone to communicate, this is so critical. It's so important that you're able to communicate, and that those changes is what we are talking. Yeah.
Dr. Mishra, you.
so just building upon what Sir spoken. See, when we say why we are doing it, when we use the technology, it's not just how the patient is getting better faster. So one of the data is what the IFS. So when I looked at the IFS first time, in a Singapore rehabilitation facility where there are like 3 IFS devices and 3 devices. So when I interacted with the physical therapists over there, and the people
I think even your audio is getting affected for
56%
some reason.
low. Okay, this is audible now?
Yeah, better.
Yeah. So it is 56% load is being offloaded from the physical therapist. So when if I have to do some so when we use a physical therapist goes and try to move the shoulder, he can do only 20-25 minutes. That's the max. In a single IFES session, we can able to move the shoulder, the limbs at bare minimum 60 to 70 times. So that's where the load goes down on the physical therapist. It is 56%. The recovery rates are enhanced by roughly 36% in the patients on the EFT-based device, because it's just not using the muscle and like just move it. Analyzing the data, so the machine
So
knows
your
how
audio
much
is breaking
power or
actually.
stimulus to give. Oh,
Okay.
okay.
You want to move closer to the machine and go off this? Yeah. Um, I think I'm getting feedback that it seems to be okay on the webinar itself.
Is it better now?
Yeah, sometimes it's better, few words are getting lost.
Okay.
Yeah.
Okay.
So when we look how to increase the efficacy, there is always when we look that there is a one neurologist in a million people in country, and that's the rehabilitation scenario. Also, it's not adequate. We also want to reduce the workload of the therapist itself. So it is 56% workload of the therapist. Second, it is a systematic in nature. So first, when we start using the brain stimulation, it's not that the first day itself patient go the IFES or the anxiety. First, we have to mobilize the bigger muscle group. They go the IFES, RT 300 weeks. Then the fine motor, they go to excite. Then they will go for the fine motor equipments. So it's a systematic activation and modulation of the limbs while we are stimulating the brain networks which are being damaged. So there is an efficacy of the treatment given both of the medical systems as well as for the patients that their recovery return faster. As we said, there's speech post-stroke. Usually when a patient goes to a hospital, like post-stroke admission happens, and they are not very conscious, they are in comatose state. There is a tracheostomy is being done. Now, when you remove the tracheostomy, it takes generally 21 days to a month to get that voice better by using the vital stims which is a certain EMG stimulation. That same can be achieved in 7 days. So just 7 days, patient starts speaking, they can start swallowing better, and then the therapy programs, begins there. So it's just that's the theory. So 3x faster they complete the patient.
If I can also make a point about cost, most of us are preoccupied with direct costs. We think about the cost of treatment. But if you think about it another way, if someone is disabled and needs a lot of assistance, and that circumstance continues, the cumulative cost of that over the years is much higher. So, apart from helping people reduce their levels of disability, improve their quality of life, and become more able again, this is one side. You actually are reducing long term costs because the long term costs of indirect costs of caregiving are extremely high. To give you one example, it's not just the person not being able to do and needing somebody to support them. Very often, there's a family member who stops working or starts working part time or gives up something in order to care for this person. So, if you look at it from an economic perspective, and that's what health economists do, you are looking at cost which actually balloons far beyond the cost of rehabilitation itself. So, in a way, it's a fallacy to think about rehabilitation as expensive. It's actually being disabled that is expensive in the long term.
So, is this technology essentially being integrated with rehab programs? For instance, somebody's asked, suppose you're identifying somebody having a stroke and you immediately rush the patient to the hospital. So, how is this robotic technology actually helping
Okay.
in?
So nothing replaces acute stroke care. Okay. So in the first few hours, in fact, the first 2 hours of recognizing that you have a stroke, you're better off in a major hospital which has people who know how to manage an acute stroke. So acute stroke care is the best reducer of disability. So I think that's the first point. You need to go to a large hospital. You need to go to a hospital which has got a neurological service which handles strokes. And that's your best chance of getting acute stroke care. There are medicines that you need to be administered as soon as possible for the person with stroke. That's very important. Now, once you've gone through the acute storm, and this can take days, this can take weeks, but very soon after the acute treatment has started to happen, people are starting to get mobilized. So you'll have a physiotherapist working with you on your bedside in all the good hospitals. So the next level, therefore, is the bedside physiotherapy. The kind of work that I'm talking about starts after the person has, now become stable, is either in a hospital ward or has been discharged and is left with some disability. That's when this form of rehabilitation is best recognized as being important. So I think rehabilitation needs to start early, but the forms of rehabilitation that happen when you're still in the ICU are very different from the forms of rehabilitation that will happen once you go to the ward, once you get discharged. And a lot of what we are talking about is later. Now, to tell you one other thing about safety and good clinical practice, obviously, when you have an acute stroke, there's a time for it to resolve. So, we will not stimulate the brain, for example, for such a person. We need to see a CT scan where whatever happened to the stroke has resolved completely before we start stimulating, because there is a risk that we will destabilize. So, you need to therefore be properly assessed. We need to choose our patients and we need to choose which treatments work for whom. Everything will not work for everyone. So, to give you an example, also in terms of good clinical practice and safety, if someone has a history of active epilepsy, repeated seizures, there are certain forms of brain stimulation we can't use. If someone has, for example, a certain kind of cardiac history, we cannot use vagus nerve stimulation. So none of this should be done without proper procedures, proper protocols, and without good clinical practice being followed. We must follow good clinical practice guidelines with every one of these because they work, and because they work, you need to choose your patients, and you need to choose what you can give them. But our
Right.
experience also is that there is something for everyone. So, when you have a wide array of technologies and therapies available, one advantage you have is that you're always able to provide something for everyone. And when I say, therefore, that this is a practice model, I mean, my hope is that what we are demonstrating will become a practice model over time. That is what I'm talking about, that we are able to offer people a much wider array of options which can be utilized for getting better, for being rehabilitated.
I'm glad you have already addressed the safety issue because there are a couple of questions on that. Like Rukmini was asking about the risks that are involved in with technology-driven rehabilitation, or like when you're using too much technology. Of course, there are these different safety guidelines which have to be followed. Then Subramaniam Padmanabhan is saying that what is the good protocol to arrest a patient who's already having dementia? I mean, arrested from deteriorating further. Questions on Alzheimer's. So, if you would like to answer, kind of, I'm
Sure.
clubbing a couple of questions. Yeah.
Sure. We'll talk about dementia. So, with dementia, there is the pre-dementia stage of mild cognitive impairment, and that's very similar to impaired glucose tolerance in diabetes. Okay. So, recognizing mild cognitive impairment actually is very, very important because it gives us a much greater option of helping a person stay well than when they have already progressed to dementia. Okay. The same with, if you think about diabetes, recognizing your impaired glucose tolerant and making the changes to your lifestyle and diet and so on, exercise and so on, actually can delay your onset of diabetes. So it's pretty much, they're very similar to each other. When we recognize a person has mild cognitive impairment or early dementia, we are able to work with them. Vivek presented the data on TDCS, transcranial direct current stimulation, and how that can, that together with oxygen, normobaric oxygen, actually has a good impact on improving memory. So we've had people go from a memory score of 64 on 100, which is abnormal, to 72, 74 on 100, and stay there for 2 years, exactly on that higher memory score, maintain there for 2 years with periodic brain stimulation. There are protocols, there are limits how much we can stimulate. TDCS is not the only thing we can use. We can use the TMS, and there are very specific TMS protocols that have been published in the journal Brain, which can be used. The new kid on the block is something called TPS, which has not yet come to this region. It's not come to Asia at all. But that's also something that's showing promise. So this technology actually is showing promise. We need to combine it with cognitive retraining. So it's about working with the person. There are simple things we do, like, for example, reminiscence therapy is where you take the person through, say, old photographs and talk to them about the incidents that happened, the events that happened. Where were you when this happened? What was happening? Where did this take place? And so on. Even going down to, say, minor details is very helpful. We also pick and choose as part of therapy things that people like doing. So, to give you an example, if I'm a music aficionado, using music as a way of cognitive retraining for me is very, very possible, right? If I have literature or art as my interest, then again, using that is going to make my cognitive retraining so much more interesting to me as an older person who's losing his memory. So, these combinations are very important. Technology with therapy combinations are very, very important. It's possible to improve, and it usually is an adjuvant to medication. So we have medication that can slow down the progress of dementia. We have new medicines that have not come to India, which actually knock out the bad proteins in your brain, but those are yet to be available here. But what we do have is medicines that slow progression. So it's very important the person is on medication to slow progression. It's very important somebody does a deep diagnostic dive to make sure that there is no reversible factor. So we have got people, for example, walking around with an inflammation of the thyroid, what's called autoimmune thyroiditis, which looks like dementia, but it's very treatable. So it's very important somebody does a deep dive to make sure that you don't have a reversible cause for what appears to be dementia. So in the beginning, a proper assessment. Once you assess the person, then of course the possibility of using things like TDCS, cognitive retraining, a whole host of Ayush procedures, all this can help the person with dementia or with mild cognitive impairment. Many people with more advanced forms of dementia have behavior problems, what we call behavioral and psychological symptoms of dementia. Again, there TDCS can be very, very useful in cutting down difficult to manage behaviors. And we have protocols for different types of behavioral problems that we face in people with more moderate to severe dementia. So you don't have to endure, you don't have to just rely on sedating them with medication. You can actually work with them using brain stimulation in order to help them settle down and be better. So, depending on what stage of the condition they are in, we do have specific options that we can use.
So what are the, I would like to bring you in, Dr. Vivek, like what are the basic, or say the pragmatic patient concerns? Because like somebody is also asking, can it be used in any type of muscular disorder? Somebody else is asking, I have a 7-year-old son with ADHD, can it be used there? So, and like how do you measure the patient outcome? How do they get convinced that yes, they will get better?
So when we look at how these devices and who are the ideal patients, so when we
Actually, I
look
think you
at
will have to shift
okay,
your position, Dr. Vivek. Your voice is
okay,
still breaking. Or maybe the,
okay. Is it better now?
yeah.
Yeah. Okay. So what really happens when the ideal patient comes because the electrodes, if we just look at the device, like we are working with a set of 12 different electrodes. So if I take an example of a cerebral palsy, where the muscles are not being developed, or any neurodevelopmental disorder for a stage, the muscles are not getting developed. Using those electrodes,
Go closer to the.
Is now voice is better?
Yeah, it starts off better, then drains out.
Okay, okay. So when we look at the 12 different types of electrode, what we can able to place, it is just, we are talking about the symptoms. What is the core at neurobiology, what we are looking for? It is the muscles which have not got the enough connections from the brain to perform at a regular function while stimulating those muscle growths. Now, be it any neurodevelopmental disorder, be it stroke, it is just the symptom remains the same, that my brain is not connected to those muscles. And if we are able to stimulate the muscle deeply and more effectively, we can able to provide very personalized care in those cases. When we talk on the reverse, that how we rate it. So there is a different standardized rating scales. For example, there is a gross motor function scale. There is a MACS, as Ashworth scale of spasticity. So we assess all those, be it children, adult, or elder, prior to starting the therapy. So that sets our baseline. Then after the 10 sessions of 10 therapy days, we do those scales again. And then again after 10. So there is a plot what we can able to put it, that this is what your baseline scores were when you came to us. Then how is your progression looks like? And usually it is very positive that the patient feels very confident that we have, for example, for stroke, we have an AI-based gait analysis. So now you have to just wear a shoe and walk on a straight ramp. Now, after 6 minutes, so we have to do it for 6 minutes, we know how many steps has been taken, how much time it was the patient took to complete those many number of steps. In 6 minutes, how much distance has been covered. So there are 12 parameters what we look for. And then at the mid of the therapy, at the end of the therapy, at follow-ups. So we know the same test being repeated gives the best outcome measure of progress.
If I can just add to that and also answer the question about ADHD, what we have done for years is do very detailed assessments. In fact, people ask us when they come to us, why do you take so much time to assess? We assess with about 15 outcome indicators on average by condition. So you saw, for example, the UPDRS plot. We do that for everybody with Parkinson's. That's why we have data, right? And so on. So Vivek mentioned some of the instruments of assessment that we use. We use it not only for precision diagnosis, because it's extremely important to diagnose correctly. To give you an example, many children with what looks like ADHD have autism spectrum features. Many children who are diagnosed to be in the autism spectrum have ADHD features. Now, unless you do a measurement, you cannot be absolutely certain whether it's one or both that you're dealing with. And this is quite critical. So the multidisciplinary assessment has to be supported by outcome measures that are internationally validated outcome measures. This is part of good clinical practice. Now, for the child with ADHD, what you need to do is reduce the hyperactivity. Because when a person is trying to work with that child, whether it's a speech therapist or an occupational therapist or any other form of therapist, they will say, oh, I'm not able to make progress with him because he's too hyperactive or she's too hyperactive. That is the problem. So our initial target for treatment in that circumstance is usually to reduce the hyperactivity. Because once you reduce the hyperactivity, you actually get access to the child. I often tell people it's like a muddy pool. You know, the sand has to settle in the bottom in order for you to see through the water. In the same way, the hyperactivity is like the muddy pool. You can't see the child until the hyperactivity reduces. So we need to choose, we need to use scientific methods of assessment. It's time consuming, and rehabilitation is time consuming. It involves a lot of people working together, but they need to come together to assess, to plan that this is what we're going to do for the child, to track how the child is progressing through treatment, modulate the treatment to suit the child. It's not one size that fits all. So you have to modulate as you go along, and you need to study progress. Rehabilitation is never a single cycle. You know, it's very rare that we say, okay, 5 weeks and we are done. 5 weeks gives us new milestones to start looking at. And that's usually the case with rehabilitation. So the mean period for most rehabilitation situations is something like 3 months. And one needs that patience and that stamina to go through this in a systematic way. Then what happens, say with a child like that, is that the therapist in your area whom you've been going through, the friendly neighborhood therapist, who really is important to you, that person is able to take over and work better with the child because now the hyperactivity is reduced. Now the child is more accessible. So we are not looking at short journeys. We are looking at reasonably long journeys. But also it's very important to understand that it needs to be scientific, it needs to be good clinical practice, it needs to be tracked and measured and validated. And of course, with all the safety procedures and protocols in place, because if you close your eyes and start doing things, you'll make mistakes. So it's very important that's where the team effort comes into play, because somebody will say, oh my God, we need to do this for this person before we start. And that becomes extremely important. The teamwork becomes very, very.
Yeah, so since we were focusing on the children, so they, of course, like, their brains are developing and presenting unique opportunities. So there is a difference in approach, or even maybe certain kind of restrictions for treating children and adults. So do you see a kind of difference in outcomes for the pediatric patient or adult patients?
So the goals are different. With each group, if you think about it, the goals of therapy become very, very different. The goals for a child are quite different, say, from a young adult who's had a road traffic accident. That person needs to get back on their feet, needs to be able to think again, needs to be able to remember again, needs to be able to get back to work because they've got their whole working life in front of them. And then that's quite different from an older person who, say, had a stroke or who's got Parkinson's, where, being independent and being able to care for oneself are the goals. So in rehab, setting the goals and being realistic about the goals is extremely important. I think that's really the key. And for each one of these groups, the goals are very different. And with children, for example, we always tell the families this. When you have access to technology and you come to a higher center like this, basically this has to be a catalyst for the rest of the journey. This is not the journey. You're not going to spend the rest of your time just coming here. This is the catalyst for the rest of your journey, and that's how it has to be. And that's how we're able to work with schools. That's how we push a lot of people to think about inclusive schools. That's how school counselors become very important people to work with. So, which the young adult, for example, I'm an IT professional, had a road traffic accident, I need to be able to go back and work as an IT professional. And while that will be the long goal, the short goal is I need to regain my independence first and start somewhat thinking clearly, even if I can't think very, very clearly. But we've actually had patients. We've this outstanding case where he was actually his frontal lobe was injured. Your frontal lobe is your social brain, and it's what helps you control your impulses and manage your social behavior. Because it was injured very badly in the accident, he actually came to us chained to the cot because he was aggressive, violent, and would not, he couldn't be restrained. It was very, very difficult to manage him. He's gone from there he went from there over a period of a year to going back to work as an IT professional. And I'm very happy to say that today he's actually a fully functional IT professional working abroad. So the point I'm trying to make is that there is always hope. That's very important, but also that the goals vary very much depending on who you're dealing with. And that's true for all rehab.
So, Dr. Vivek, I would like to bring you in. Then how are you personalizing treatment protocols? Because I'm sure the patients and their families, they're all kind of more anxious about what they can expect in realistic terms.
Right. So when we talk about in how we personalize the therapy, as we just discussed, that it's based on our comprehensive assessment. So usually when I see and we goes to any medical center and the report has been given or 2 or 3 pages, and that is what your whole intake history and the plan has been given. When we do the comprehensive assessment, be it a physical therapy, occupational therapy, psychotherapy, there are the medical officers' instructions, they do electrophysiology. It generates a picture which can help addresses their relevant problems. So it's not just we write, 20 hours of physical therapy. It defines in that 20 hours what we are going to do. So I will just take the same example that how we able to personalize. Now, the same gentleman who had the frontal lobe injury, post-stroke behavior, like his post-traumatic brain injuries behavior was really bad. In those cases, I would have chose that, why don't we go for a TMS, which is the most robust technology to control the behavior. But then we worked with the neurosurgical team where we found that there is a totally skull reconstruction was done. There was a metal plate and implant just where we want to stimulate. So we don't want to, stimulate those implants on the TMS because then there is always risk of being heating up. So what we did another one CT scan. Can we able to put the TDCS for him? Okay, the place what we wanted to place the electrodes, again, it is just outpatient. So we have to go with the scans itself. And we found, yes, we can able to do. So again, this is a personalization. So if there is no personalization, we would have said like, there is no TMS, we can't do anything. But then we chose the TDCS for him. Okay. Then coming to the physical attribute for him. Can we able to directly stimulate or use the Excite bike for him because he was having a problem. So, he was so frustrated that he's unable to type or unable to use the phone. So we started working with his gross motor functions, like can he move the hand, and then coming to the fine motor with the occupational therapist support, and then he able to start typing. So just like this case, for each child, yesterday, we had one of the case series what we are doing. So there is a kid, he is with us for last 6 years. And I was telling one of our physical medicine and rehabilitation physician visiting us. And I said, see, there is a kid with a neurodevelopmental disorder. He is being plus, he is non-verbal, he is unable to walk, eat and all. And then I took him for the 6 years. And then the kid came. So before he saw the kid, he asked the parents, oh, can he walk or, can he use the restroom by himself? They said, yeah, that was a problem, which is 5 years ago. And after four years back, he started doing all those things. And, to my surprise, usually this kid is very shy. And then this new physician asked him during the neurological examination, and he's just perfectly, he did all the tasks one by one. So then the physician asking me, like, come on, you were telling me that, the person is having a neurodevelopmental disorder, features of ASD, features of CP. But he is doing perfectly well. I still see that is the progress what we have made in 6 years. And the parents were there and saying, now he's able to speak in, words like short sentences of 3 words to 4 words. So for him, we developed the plan. So it's not the plan is you come and, it is just like that sci-fi movies that all the devices are put on you. First, we start with the physical functioning. We work with the physical therapist. Then we see you over the age of 6. When he became the age over of 6, we use TDCS for his speech development. Then we use neurofeedback for bringing his attention, able to focus, including the neck control. Because unless you have to, he's sitting on like, his like head tilted over his shoulder. But when you do neurofeedback, it's gamification. So he started sitting back. We did the IFES for enhancing his trunk control because he was always slouching. Now, when we put the electrodes, it trained those muscles. See, so this is the personalization that what we able to bring for children, especially for the children, so as for the adult with stroke or traumatic brain injury.
And I just want to make the point that with the same child, the medication list, he needed a lot of medications to just calm him down when we started working with him. And for a young child, he was on fairly high doses in order to keep him functional. I'm so happy to say that the medications have progressively come down. He's on less and less and less and less with each 3-month visit that they have with me. And I think that's the importance of working with non-drug therapies, non-pharmacological therapies like this. They bring to the table that advantage that the need for medication comes down. So it's not that medication is not important, it's extremely important. But obviously, none of us like to use too much of it. And the families are also very concerned when a lot of medication is being used. And the power of rehab and the power of non-pharmacological therapy is also that you're able to bring people off medication progressively over a period of time with a lot of caution, with all the safety procedures built in.
Yeah, Dr. Krishnamurthy, maybe you could also quickly reiterate the point about the importance of, as you were mentioning, DIY, do-it-yourself guidelines, which is also an essential part of treatment protocol. I mean, patients do need to follow up.
Oh, yes. I think, I'll give you an example. You can buy things off Amazon, for example, which are stimulator devices. And quite honestly, you could do yourself harm. So it's extremely important that there are certain things you don't try at home. And a lot of these things are things that you don't try at home, not if you're a patient. Doing something as wellness is a completely different ballgame in a perfectly healthy person. The same thing a patient trying to do is not wise at all. This is one. The second is rehabilitation obviously needs to finish with things that you can do to help yourself at home. This is extremely important. And in a country like ours, one of the things we are blessed with are families that are happy to work. I think that's, very few of our patients don't have anyone to help them. Everybody has somebody who's willing to help them. So training families to work with people, giving people tools that they can continue to do is a very essential part of rehabilitation in a country like us. It's very important that we teach the caregiver. Sometimes it is a family member, sometimes it's a paid caregiver, somebody who accompanies who's looking after the person. But we can transfer a lot of skills during a rehabilitation process to them. And that really helps too. We've gone ahead and innovated even further. We've now developed a whole DIY program.
So I am able to hear you clearly, but I am receiving some messages about low audio. I'm not able to figure out. I'm not able to figure out why is that happening. So
okay. Is this a bit better now?
Yeah, I am able to hear you, but I have received messages that your audio is low.
I'm so sorry. I'm going to try and be as loud as possible because we're coming to the end of the webinar.
Yes.
The third thing is that we've gone ahead and innovated these kits, which are, Ayurveda naturopathy kits that we can actually give people to do at home. We've got instructional videos that they can follow. And these things are follow-up things that we do as part of our Seva program. We find that very important because it supports people, it gives them an anchor that they can work with. So, and of course, it's natural healing, which in so many ways can be extremely helpful. The other day I was lecturing on the vagus nerve. at a national conference, and I was pointing out that today we use an electrical device, but there are other people who are jumping into ice baths, and our sages were standing in the cold water of the Ganges. I mean, at the end of the day, all this stimulates the vagus nerve. So, in a sense, therefore, there's much you can do to help yourself. And I think that those skills need to be transferred as part of rehabilitation programs to families, because that's what helps people stay well when they've stopped coming regularly for therapy. So I think this is something that we need to also keep in focus.
So also there are a lot of questions on whether this technology-led treatment helps in autoimmune disorders, or it helps in pain management of arthritis, or it helps in reducing, diagnosing, evaluating properly at an early stage your anxiety and stress levels, the brain fog after post-COVID. So there are a lot of these very.
I will answer that in one line, since
Yes,
we are
sir.
short of time.
Yes.
So dysautonomia, the autonomic nervous system being disturbed, is a big part of many of these conditions. Long COVID, chronic anxiety, pain syndromes like fibromyalgia, autoimmune disorders. The commonality is a disturbed autonomic nervous system. Vagus nerve stimulation is excellent to stabilize the disturbed autonomic nervous system. So yes, and then of course, for pain, we have functional magnetic stimulation that helps. For anxiety, we have TMS that is helpful, TDCS that is helpful, neurofeedback that's helpful. So yes, there are a number of possible solutions that can be applied depending on the patient and their condition. So the technology definitely offers hope, but one has to evaluate people properly and choose in a very personalized manner which technologies are most useful to this particular individual.
I would like to end with one question from Abhishek, and he himself calls it a provocative question. He says, is it theoretically possible, or no, is it possible for any technology to hack or fundamentally alter an individual's consciousness, personality, or core memories?
Okay. Hans Berger, the inventor of the EEG, famously said, a machine can neither replace common sense or intelligence. So I think technology has limitations. But what we have seen, and I think that this is extremely important, is when we work with people with mental health conditions, for example, that are impeding their conscious awareness, impeding their ability to function. And you use the word finding your potential. When we work with people, especially young adults, who have for one reason or the other lost their way and are struggling, what we are able to do is to unlock their potential over a period of time. So I think technology has the power, non-invasive brain stimulation definitely has the power to unlock human potential when delivered the right way with all the right supportive therapies. I mean, I would be doing a huge disfavor if I did not acknowledge the role of the psychologist in bringing about those changes too. So I think it's that combination of technology and therapy that can definitely help people find the best version of themselves. And I think that's what we all want to be. We all want to be the best versions of ourselves.
So I would like to thank all the participants for sending in their questions, which helped to make the decision more lively and informative, and to our panelists for sparing your valuable time. As we understand, the non-invasive stimulation of the brain with robotic rehab could be a far more effective tool in treating people with limb weakness, Parkinson's, cerebral palsy, epilepsy, dementia, Alzheimer's, and other brain disorders. I'm sure there have been quite a few valuable takeaways for the listeners. Today's webinar on where precision technology meets holistic healing was presented by the Buddhi Clinic, Chennai, under the Hindu Wellness series. Thank you all once again.
Thank you so much.
Thank you.